hemodynamic monitoring, whenever a patient present to you, your monitoring of the hemodynamics starts with the very first sight of the patient. So how? You see the color of the skin, you see the temperature, then you can see pulse rate by simply palpating peripheral pulse or the central pulse. You can see the mental status of the patient. Then you can make, you all must be doing measuring the blood pressure of the patient with the non-invasive method, auscultatory method. Then you can also, one of the important tests, that is the capillary refill test, and other is the urine output. So if there is an adequate perfusion peripherally, our kidney, we can easily measure the peripheral tissue perfusion with the help of the urine output. If the urine output is decreasing, that means peripheral perfusion is not good, or kidney is already, there has been some injury in the kidney. So these are the basic non-invasive parameters through which we can assess the hemodynamic status with the very first presentation of the patient. So here you can see this mottled appearance, these hemorrhagic dark spots, dark or purple, reddish purple spots all over the body. So this is the typical picture of the mottled scene seen in shock patients, septic shock patients in ICU. Then coming to the, this is an important test. Usually people don't do it. Doctors, they usually skip this test, but this is a very important test. How to do it? Just you have to press the nail of the patient and to blench it so that it becomes white. And once it becomes white, just leave it. Then you will see that within a 2 second there will be a gushing of the blood. It will change its color back to pink. But if it takes more than 2 seconds, that means you can easily tell that either the patient is dehydrated or the patient is in shock. That means peripheral perfusion is not good. Something is not right in the perfusion of the patient. Okay, now coming to the another method, that is the by measuring the blood pressure. So you all must be measuring the blood pressure on your own, and you all must be knowing it this very thoroughly, because this must have been taken in your physiology classes and all practicals. So there are the indirect methods and direct methods. We'll be stressing more on the direct method, but just an overview, that is auscultatory technique and oscillatory technique in the non-invasive blood pressure monitoring. In our monitors, in our ICU, we have both the types of measurement of blood pressure. Non-invasively भी कर सकते हैं, invasively भी कर सकते हैं. So auscultatory, as you all know, you need a BP cuff, a meter, and a pressure manometer, and then you need a stethoscope. So these all things you require, and you inflate the pressure and then deflate. The Korsakoff sound, you all must be knowing it. So first sound will be systolic and muffling will be the diastolic blood pressure. This is the oscillatory, the machines which we are using in our OPDs and in our home. There is electronic pressure sensor, that is the transducer, that detects the when you inflate the cuff, and that change in the pressure of the blood flow, that detects that and senses it, and then gives the electronic reading of the blood pressure. So this is the oscillatory method. Now these are the advantages. This is simple method, quickly can be done. You can do nothing more required, just a little expertise. Anyone can do, even the nurses can do. So just you need a little training and there is no complications. But these are not accurate where if the patient is stable, not much sick, then these methods are accurate. But when the patient is in shock, the patient has come to the ICU, he is in septic shock, cardiogenic shock, then these methods are not accurate. It is sometimes it becomes very difficult to hear the sounds, and also in low flow states they show so much of variations in the readings. Also, these are the various limiting factors. You proper fitting of the blood pressure cuff, the length and the width, you all must be knowing this. And if this is not proper fitting, then the false high and false low reading. So this is about the non-invasive blood pressure. Now, other methods of non-invasive monitoring of hemodynamics, you can do ECG. In ECG also, you can, what do you assess? Assess the contractility, mainly the cardiac condition. what is going on in the heart. Through the waves you can say whether there is ischemia, whether there is dysfunction, or with the blocks, and with all the waves there are multiple myocarditis, and also you can assess the condition of the heart. So this is one of the most important, one of an important non-invasive method through which you can assess the condition of the heart. Another one is the echocardiography. So you all must be thinking that echocardiography is a very, although it is a specialized investigation usually done by a cardiologist, but in ICU, in critically ill patients, now it has become a mandatory tool to be used by all the intensivists. It is just like it has become like a stethoscope. So with the help of the echocardiography, you can assess the intravascular volume status of the patient, whether he is in hypovolemia, fluid overload. You can assess the fluid responsiveness. This slide has given you a brief overview what all you can assess with the echocardiography. So you can all in details you can learn it later, but I will tell you just in brief that with the help of the echocardiography, with the help of assessing the IVC, we can assess the preload of the heart, that is the volume status, whether the patient is in overload or whether the patient is in hypovolemia. Then you can assess with easily with the echocardiography, you can assess the contractility, that is the pump of our body. So cardiac status you can assess whether there is LV dysfunction, RV dysfunction, or then, with the help of this echocardiography, you can also assess the cardiac output, calculate with the various parameters, and the afterload also. And the one important thing which we are routinely doing with the echocardiography is to assess the fluid responsiveness. So, whenever a patient comes to you in ICU and he's in shock or in emergency, if you have the echocardiography over there, then you can, with the help of this echocardiograph, you can immediately measure the IVC status, and then you can measure the size of the IVC, and also you can measure the change in the diameter of the IVC variability of the IVC diameter. How much variability? If it is more than 18%, then patient is fluid responsive. Okay. Now you can also do passive leg raising test, and then you can assess how much cardiac function or the cardiac output has increased. So these are the simple methods, and with echocardiography you can easily assess whether you have to get more fluid or not. Now these are the basic, come on, I mean these are the important thing which we'll be discussing about hemodynamic monitoring, and this is the invasive hemodynamic monitoring. So what all comes under invasive hemodynamic monitoring? Although this is a very vast topic, cannot be completely covered in a single lecture, but I have tried to compile it so that I can give you a basic idea of all these parameters. Like, invasive hemodynamic monitorings include intra-arterial pressure monitoring. So what is intra-arterial pressure monitoring? That is the invasive arterial. Through the EP cuff, we were doing non-invasively. Now we will be uh, inserting a arterial cannula, and we will be directly measuring the blood pressure through that cannula. Another second one is central venous pressure. So what is central venous pressure? Central venous pressure is the pressure inside the central veins. Through this, we are assessing the preload of the heart, pressure in the right atrium, mainly in superior vena cava. So that is what is signifying the central venous pressure. Now, another one is the pulmonary artery catheterization. So this method of hemodynamic monitoring is not used currently. This is not in much use, but through this pulmonary artery catheterization, we can measure pressure in veins, central veins, right atria. Even we can measure the cardiac output, we can measure pulmonary artery pressure, pulmonary artery occlusion pressure, that is pulmonary wedge pressure. Then we can measure this another term, that is the mixed venous oxygen. So you can see what is the purpose of all of this. What is the purpose of all these monitoring what we are doing? We want to see whether the tissues are getting adequate oxygen or not. Okay, so now coming to the first, that is the intra-arterial blood pressure. This is invasive, as we all know. What are the indication? So whenever the patient is in refractory shock or the patient is in severe shock and you are giving him vasoactive drugs and you need frequent titration, patient is very sick, so for the proper and the correct measurement of the blood pressure. Second is if the patient is having unstable blood pressure. Third is if you require frequent ABGs, patient is really sick, lying on ventilator, multiple vasopressors are going on, and you require, patient is on CRRT, you require multiple ABGs, frequent testing. So for other testings, you can use CVP, obviously central lines, but for arterial sample, this can help. And again, if you are not able to record BPO on non-invasive blood pressure monitoring. So what are the contraindications? So before doing any procedure, you should know the indications and the contraindications, and then proceed towards how to do that procedure and how to manage that complications which can appear while doing that procedure. So contraindications are if there is an absent pulse, if you are not feeling a pulse, you have, first of all, while inserting cannula, arterial cannula, you palpate the pulse, and if there is no pulse, then it will be very difficult for you to insert arterial cannula. Mind you, you will not be able to insert it. If there is a condition called Berger's disease, any kind of arterial disease, that is an absolute contraindication. Burns over the cannulation sites, Raynaud's phenomena, or there is inadequate circulation in the extremities. So, for that, what we do the Ellen's test. That is the most important test, and that should be done always whenever you are trying to put a arterial cannula. So, what do we require? We require an arterial catheter, as you can see in this diagram. This a red one, that is an arterial catheter with a stopcock, and then you will need a pressure tubing that will connect the arterial catheter to the transducer, then pressure tubing, pressure cable, and there is a pressure bag lying on the IV rod, that 500 flush. For you will need a normal saline solution for the flushing, and then from that transducer there is a black color wire that goes to the monitor, and that will give the recording. So this is the total apparatus what we will be requiring. Okay, this is the pressure transducer we are routinely doing in our ICU, calculating this, doing this invasive intra-arterial recording. And so coming to the Allen's test, and this is a very important test. This should be done in all the patients in whom you are planning to insert arterial cannula. So it is used to assess collateral perfusion. What you have to do, just ask the patient to clench his fist, to make a fist very tightly, and then press both the ulnar artery and the radial artery, occlude them, and then ask him to release. And then you just see how much time will it take to जो palm है उसका color, it becomes again flushed. So if it is, usually it is less than 6 seconds, that means peripheral perfusion is adequate. You have to release the ulnar artery, and you have to ulnar artery you have to release, and then you will see whether the peripheral collateral circulation, because our hand is supplied by the two arteries, radial and the ulnar artery. So if the pink color appears within 6 seconds, that means the collateral circulation is working. You have to check on both the sides, not on only on the one side. So you have to check both the arteries. Okay. Now, this is another important thing that you must all know, that all the recordings of the pressures, like central venous pressure, or this intra-arterial pressure, they must be done in the phlebostatic axis. Now, what is this phlebostatic axis? This is usually this is taken at the level of the fourth intercostal space, and in the where the fourth intercostal line on the fourth intercostal space and the mid axillary line, they intersect. So that is the point. In that axis, you have to take the all the readings. You have to do zeroing. Your level of the stopcock level should be at that axis, and you have to do the zeroing all the times in the neck in that axis, and then you have to calculate the pressures. So if the patient is lying down on the bed, then that stopcock should be at that level only. और अगर पेशेंट को आपने 30 to 40 डिग्री एलिवेट कर दिया है, तो आपको अपना stopcock level भी you have to elevate to match that axis. Now, what is this zeroing? Why do we do this zeroing? So that we can zeroing का क्या मतलब है? Zeroing का मतलब है कि हमें atmosphere level से zero करना है. Pressure should be equal to atmosphere pressure. When we open the stopbox, we open it to the atmosphere, and now we have done the zeroing, and then we again close it so that whole circuit is maintained, and we measure the pressure in the artery. So we are measuring that pressure as compared to the atmospheric pressure, outside pressure. So that's why we are doing the zeroing. So this is all this slide is showing when you have to do the zeroing, leveling. That means at the level of the phlebostatic axis. So leveling should always be done before and after insertion, or whenever you move your patient or you move the head end of the patient or the bed is moved. Zeroing should be performed before the insertion and whenever you are taking the reading. So whenever you want to record the actual blood pressure, you should do the zeroing first, and then you should take the reading. Now, what are the potential complications? So this is another important slide that you should know. There can be a hemorrhage while inserting, so you should know what are the coagulation profile of your patient, what is the platelets, whether the patient is in uremia, platelet dysfunction. So in all these patients, you should be ready ahead, and you should do these procedure cautiously. You should do in a single prick so that there should be no hemorrhage. Otherwise, also there can be bleeding, there can be local hematoma if you haven't done the procedure in single break. There can be air embolism, there can be a risk of infection if there is a burn, if there is a local infection, and then there can be a impaired circulation if there is you haven't done the Allen's test. That can, mind you, that can you can lose the limb if the peripheral collateral circulation is not good. Now, this is another important slide that all of you should know, that no drugs, never should be injected in the arterial line, because what arteries are doing? Arteries are going to the various tissues. They will take that drug. When you inject that drug, they will take that drug to the various tissues like muscles, and that drug will get concentrated there, and that will lead to necrosis. I have seen these cases. This limb, they all going into gangrene, blackening, and patient usually lose their limb. So never inject any drug in the arterial line. So this is the arterial pressure waveform. जब आप monitor पे देखेंगे, this will be the picture. These are the waveforms you will be seeing. As you can see, there is an upstroke. Upstroke is because of the left ventricular contraction. Then after that there will be a downstroke, and there will be a notch. That is because of the aortic valve closure. And then when it comes to the base, that is the diastolic pressure. So the systolic pressure and diastolic pressure. So with the just by looking at the monitor, you can tell what is the arterial pressure, systolic, diastolic, and whether the patient is in good hemodynamic condition or not with the appearance of these waves. These are the normal waves, and the difference is the pulse pressure. Now, you should know that when can these readings be normal, incorrect. So not normal, incorrect. If any of the component like the stopcock, pressure tubing, or the arterial cannula, if there is a blockage, if there is a kinking, or if there is a occlusion, or if the stopcock is not, you haven't done the zeroing properly, you haven't kept the transducer or that stopcock at the phlebostatic axis, so these all will lead to error in the reading. So these all should be taken into account always when you are doing the recording. And the another important term you can see here is the damping. So this you should know what is damping. Look now in this slide, as you can see, the normal, this is the on the left side, this is the normal arterial waveform, and on the right side this is the damped, over damped. So what has happened, because of the damping, जो normal peak था वो कम हो गया, the waves have become shorter. So what, this will give a falsely low blood pressure. So if we don't know that uh, our circuit, or there is some problem in our circuit, then we'll be recording the falsely low blood pressure. So what can be the causes? Just remember dampening, that means कि लो आ रही है, इसका मतलब कहीं ना कहीं रुकावट है, प्रेशर पूरा डिलीवर वहाँ पे ट्रांसमिट नहीं हो पा रहे हैं सिग्नल्स. सो देयर कैन बी एयर बबल इन योर circuit, pressure tubing, or there can be your tubing. Mind you, that pressure tubing, that is not a normal IV tubing, that is a hard one. So if you have used over compliant, then also there will be a dampened graph. If there is a kinks, if there are clots, so any kind of obstruction, or these overdamp can occur. First of all, you should also check, first of all you should do the zeroing in that case, and there is a flush test, so you should see there is over damping or not. And if there is no damping, then this graph is showing that your patient is in hypotension. You have to act immediately. So now this is the another graph, that is the normal graph, and here you can see a very tall peaked waves. So what are these showing? That means this is under damping, कि बहुत ज़्यादा नॉर्मली हाई ब्लड प्रेशर रिकॉर्डिंग आ रही है. इफ़ यू हैव यूज्ड लॉन्ग ट्यूब्स, overly stiff, very stiff pressure tubing you have used, or there is increased vascular resistance, or non fully opened stopcock. जो stopcock है उसको आपने पूरा नहीं खोला है, तो ये, but how will you know that these are normal or these are abnormal? This is a dampening or under dampening, or these are normal recording. So how do you know? So you will do a simple flush test. What you will do, you open the cannula and you will, sorry, open the stopcock and you will do the flush. What flush? Normal saline, whatever is there in your bag, you will just flush the fluid in the artery. As you can see, this the tall square wave, that is the flushing of the fluid. And after flushing, normally there should be only one spike, one or two spikes. If there are multiple spikes, that means this waveform was underdamped. And if, as you can see in the lower diagram, that if there is only single spike or there is no, then that is overdamped. So with the help of this flush test, you can easily know that your waveform is correct or not, and then you can do zeroing, and then again you can measure the correct recording. So this is how we do, and we do this flush test and this measurement of blood pressure, measurement of pressure in that artery. We are doing all these things in while measuring central venous pressure also. So central venous pressure will also be measured at phlebostatic axis. Then you have to do zeroing like you are doing in arterial blood pressure monitoring. Then you have to check that damping also you have to. So all the things are same, it's just that the catheter, cannula or central venous catheter is different. You have to insert it in a vein instead of the artery. The techniques are same with the Seldinger's technique. So now, as I have already told you, Central venous pressure, it is a pressure of blood within the right atrium, is the central venous pressure, because all the veins, they are draining the blood in right atrium. So with the help of the central venous pressure, we can tell that, yeah, this must be the pressure in the right atrium. So we don't have to enter into the right atrium directly for the measurement, and normal values are 8 to 12 centimeter of water. So क्या बताता है जो सेंट्रल वीनस प्रेशर है? ऑल द ब्लड इन द सेंट्रल वेन्स, दे आर कमिंग फ्रॉम द peripheries. So it will tell the intravascular volume status. So if our CVP is very low, that means patient is either dehydrated, so you have to hypovolemia, so you have to administer fluid. Or it will also tell the right ventricular function. It will assesses the right ventricular function, that is in the whether the pumping is accurate or it is not exactly the right ventricular function, and patient responds to the drugs or the fluid. So this is all. The most important thing is we measure the intravascular volume status. Now, so we can insert this central venous catheter. Some of you must have inserted, I guess, maybe in your or must have seen in your postings. So we can insert it in external jugular vein, internal jugular vein, or in subclavian vein, or in femoral, not in. Okay, so these are the three sites: jugular, subclavian, or femoral. And these all things which we require, there is a proper set having central venous catheter, various syringes with the guide wire, and you will be needing drapes, disinfection. So disinfection, asepsis should be maintained in all these procedures, because you are directly entering into the major veins and arteries. Now, with the central venous pressure, we can measure it with the manometer method, or with the method which I have already explained while measuring the intra-arterial pressure, that is a transducer, with the help of the transducer, that is very simple. And with the manometer also, earlier we all were doing this with this manometer method, and still sometimes we use it. So with the help of a simple manometer, we can measure. And the thing is that here also, the stopcock of the center, this manometer, glass manometer, should be at the phlevostatic axis. So that is the only difference. Just in place of the transducer, there is a manometer, and that is connected to your vein, and the other end is connected to your flush bag. So rest all things are same. And this is with the help of the transducer. Here in picture you can see that this is the transducer with the stopcock. Okay, now this is the central venous waveform. You all must be knowing there are three positive waves, A, C, V, and two descents, that is X and Y. A telling the atrial contraction, C closure of the tricuspid valve, and V positive wave is the ventricular diastole. And the two descent, atrial relaxation, X is telling about the atrial relaxation, and Y is tricuspid valve opening. So this all you must have been knowing. Now, central venous pressure is decreased. So if while you are monitoring a patient and you have low central venous pressure, the patient may be in hypovolemic shock, whatever is the cause, dehydration, fluid shift into the extravascular space, or like in capillary leak syndrome, or there is a hemorrhage in trauma patients, or the another reason, if your patient is negative on breathing, negative pressure, that means spontaneously breathing, because while we are doing spontaneous breathing, so that is negative pressure breathing. And central venous pressure is increased if the patient, we have given a lot of IV fluids. So IVC, or central venous pressure will be high, more than 12, more than 14, if the patient is in heart failure or pulmonary stenosis because of the increased resistance, increased resistance, vascular resistance, and in patients and on positive pressure breathing. So this is an important point, because in ICU, patients are on ventilator, mechanical ventilator, invasive mechanical ventilator. So they are on positive. Usually our breathing is negative pressure breathing. So you have to take it into account that while the patient is on mechanical ventilation, so there is slightly increase in CVP, or there are other causes also. Now, again, you should know what all complication can occur while inserting a central venous line. So they you can, if while doing the most common, you can cause a pneumothorax, hemothorax, more common while you are inserting subclavian, but can occur in the patients, can occur when you are inserting even in the jugular line. Because in ICU, the patients are on positive pressure ventilation, so lungs may be in a COPD patients, and the lungs may be inflated, overinflated. So you have to look all these factors, you have to take into account. So whenever you are inserting a central venous cannula, so you decrease the PEEP, that is positive end expiratory pressure on the ventilator, to zero, so that the apex of the lung that goes down, and there it decreases the chances of pneumothorax or hemothorax. Then there are other complications like infections and venous thrombosis or damage to the artery. You can puncture artery and there can be a hematoma formation. And if your catheter that goes into the heart, right atrium, then there can be a arrhythmia. So you always have to look on the monitors while inserting that catheter. So once you see the arrhythmia, just withdraw it, pull it out a little. Then there can be a hemorrhage, air embolism. This is important complication, air embolism. So what you have to do, you have to, whenever you are suspecting that there is sudden there is air embolism patient, then in what position you should give it? You should make it in reverse Trendelenburg position, because you have to avoid to so that जो एयर एम्बोलस है वो आपके ब्रेन में ना जाए. So you have to keep the patient in Trendelenburg position. So you should know all this. Now, coming to the pulmonary artery catheterization. This is nowadays we are not using it routinely, very rarely in certain conditions. We are in not we are not doing it. It has been used in just a few conditions, because now non-invasively we are doing it much better with the help of echocardiography and other measures like measurement of the cardiac output with other techniques. There are a number of other techniques through which we can measure the cardiac output with the intra-arterial cannula, that is LIDCO and other etc. etc. So these techniques has almost have become an obsolete, but still in some centers they are doing pulmonary artery catheterization in certain conditions. So you all must be knowing that is the we insert a triple lumen catheter, that is the Swan-Ganz catheter. And what all we are measuring, बस ये याद रखना है, जहाँ जहाँ से ये जाएगा, that everything will be measuring. Like it will measure central venous pressure. When right ventricle, say you have to go through very fast, you should not stay in the right ventricle, otherwise there will be arrhythmias. And then you will be measuring the cardiac output, and then you can multiply with the surface area, then it will be as cardiac index. So then you will be measuring when it enters into the pulmonary artery, you will be measuring pulmonary artery pressure. Then, for measuring the pulmonary artery occlusion pressure or the pulmonary wedge pressure, then you have to proceed it further into the pulmonary artery and you have to wedge it over there. And then you will be measuring the pulmonary capillary wedge pressure. So these are the various pressures you can record with this catheter. Then there are certain derived parameters you can calculate. You can take the blood and you can measure the SVO2. So what is this SVO2? SVO2 is mixed venous oxygen saturation. So mixed venous oxygen saturation. So again we are coming to the oxygen level. And what is this mixed venous oxygen saturation? This is the saturation of oxygen in the blood which is coming from the periphery in the veins. And when we are measuring this mixed venous oxygen saturation in the pulmonary artery. So this is known as mixed venous oxygen saturation. Uh, uh, and if we are measuring that this oxygen saturation in the central line, जो हमारी central line होती है, central venous catheter, then that will be the venous saturation, central venous saturation. So what is the difference? Actually दोनों जो हैं वो periphery का ही बताती हैं, लेकिन जो central venous catheters हैं, there the blood supply is coming from your heart and the arms, but because inferior vena cava is not draining in that catheter, and also the coronary veins. So we say that this mixed venous saturation instead of that central venous saturation is more accurate. But they are used. Central venous is used in surrogate as a surrogate for that for this mixed venous saturation. So both of them, because that can be easily measured. So what are they telling? They are telling about the oxygen saturation in the blood coming from the tissues. So they will tell how much blood, how much saturation is there. If this mixed venous saturation is decreased, normally it is 70%. If it is less than 70%, then that means there is more extraction is going on in the peripheral tissues. Our tissues, they are extracting more. If if the patient is in shock, then that will tell that there is more extraction. And if this central venous saturation is normal in spite of the patient is in shock, if it is normal, that means there is no increase in the extraction of the oxygen. So that shows that our body is compensating, is doing the compensation for the shock by increasing the cardiac output. That means till now no increase in oxygen extraction has takes place, and there is only increase in cardiac output. So increase in cardiac output is the first mechanism whenever a patient in shock. So with the increase in cardiac output, body tries to maintain the peripheral oxygenation. Now once there is further worsening of the patient condition and the patient goes into refractory shock, then despite of adding vasopressors and all the inotropes, if the patient is not peripheral oxygenation is not maintaining, tissue oxygenation is not occurring, then the tissue starts extracting more and more of oxygen from the blood. So this mixed venous oxygenation started decreasing. And if this also doesn't compensate for the shock, then third compensatory mechanism is there will be anaerobic metabolism in the tissue that will increase the lactate level, so and will cause metabolic acidosis in the body. So so by this you can understand that what we are doing, why we are measuring all these pressures, and why we are measuring this central venous mixed venous oxygen saturation. So coming to again to the pulmonary artery catheter, you can see this is a triple lumen catheter. There is a thermistor port, red color. There is a right atrial port. There is a pulmonary artery port, and there is at the tip there is a balloon, and there is another port, balloon port for the syringe to inflate the balloon. So this is a Schwangen's catheter, and here you can see that this catheter is going from the veins, central veins, then coming to the right atrium. Here you have proximal right port of the right atrium opening into the right atrium, then you go pass through to the right ventricle. If there is a arrhythmia while you are passing, while you are doing this procedure, and there is arrhythmia, ventricular arrhythmia, VFVT, that means your catheter has either pulled back into the right ventricle, so you have to immediately pull it back, or just in that case you have to pull it back because you will not be able to proceed further. So if there is arrhythmia, that means your catheter is in right ventricle. We never do any recording of pressures in right ventricle directly. So this catheter, via the right ventricle, it goes to the pulmonary artery. So there is a thermistor port, there is a distal port for pulmonary artery pressure measurement, and there is a balloon. Then when we proceed further in the lungs and at the level of the pulmonary capillary, we wedge our balloon over there, and you can measure the pulmonary capillary wedge pressure also with the help of pulmonary. With what are we doing with all the measurement of these pressure? We are distinguishing the various types of shock, whether it is the cardiogenic shock, whether it is obstructive shock, whether it is a hypovolemic shock. So in hypovolemic shock, CVP, central venous pressure, will be low, but your pulmonary artery pressure and capillary wedge pressure, they will be normal or low. So with the help of these various pressures, you can easily know the type of the shock. So you can assess the fluid status, cardiac output measurement, SVO2, that is central mixed venous oxygen saturation. Then you can calculate oxygen delivery. Remember from the first slide, oxygen consumption, peripheral vascular resistance. With the if there is increase in peripheral vascular resistance, then that will be showing that there is pulmonary arterial hypertension. The cause of the right ventricular failure is pulmonary arterial hypertension. Systemic vascular resistance, you can calculate that if there is increase in systemic vascular resistance, that means then that can be the cause of left ventricular dysfunction. So with the help of all these are the derived parameters actually. So as I have already told you, the cause, what are the indications to identify the type of the shock, cardiogenic, whether it is cardiogenic, hypovolemic, obstructive, distributive, and monitoring the effectiveness of the therapy. Now this is the diagram how the waves look when the catheter is passed through the heart. So you all know how the waves of the right atrial pressure, ACV, then when catheter enters into the right ventricle, these long ventricular pressure waves, they appear. But if there is a VT, then you know that this is not correct and you have to withdraw it. So after that, when the catheter, it enters into the pulmonary artery, so there you can record these the waves will become not peaked, there will be smoothing of the peak, and you can calculate pulmonary artery pressure. And when it enters into the lung, into the capillaries, there we can measure the pulmonary capillary wedge pressure. So if there is a left ventricular pathology, then the cause of the shock can be because of if there is a left ventricular pathology, this pulmonary capillary wedge pressure will increase. So this is just the various combination and permutations of these pressures. Then you can easily tell what is the type of the shock. Now again, complications, there can be arrhythmias, cardiac heart block. This is not an easy procedure. This is a very risky procedure, and in the patients who are really sick, this can be very lethal also. So there can be complete heart block, there can be endobronchial hemorrhage when you proceed the catheter into the capillaries. Then there can be bleeding also can occur, pulmonary infarction can occur. Catheter cannot and entrapped in the ventricle, it can coil, or it can not in the pulmonary arteries. Then there can be valvular damage, thrombus formation, incorrect placement, or balloon rupture. So these are the other complications. So these are the various complications. Now coming to this slide, these are the derived parameters. As I have already told you, you can calculate cardiac index by measuring the cardiac output. How do you measure a cardiac output? By the thermodilution technique with this catheter, and there are other methods also. So cardiac output monitoring is another type of hemodynamic monitoring. So with the pulmonary artery catheter, we can do thermodilution technique and measure the cardiac output, and by dividing with the body surface area, you can calculate cardiac index. There are other methods also like LIDCO, PICO, There you use arterial cannula, invasive arterial cannula. So those techniques are we are using those techniques nowadays for calculating cardiac output. Then you can calculate systemic vascular resistance, pulmonary vascular resistance. These are the formulas you can see. Then mixed venous oxygen saturation, as I have already told you, you can directly measure with these formulas. So these are the derived parameters, and these are the normal values of mean arterial pressure, cardiac output, cardiac index. So you should all know these values. So I guess we have completed our discussion on hemodynamic monitoring, and I hope that you have understood at least the basics. Thank you.
Friends, mark your attendance and leave the class, please. Anubhav, Ashish, Jasprit, Mahima.